for entrepreneurs. Working towards the SDGs. working towards the SDGs around.
Good afternoon, and good morning or good evening for those who are on our live link. My name is Greg Garrett. I'm the director at DNDI, which is Drugs for Neglected Diseases Initiative based here in Geneva. And today we're going to be looking at SDG 3 health and how can we finance the investment gap that we're seeing today, and in particular look at the case of hepatitis C, a disease which, as you'll learn, is something that we can eliminate by 2030 if the right political will and financing is in place. We have a very good lineup of distinguished speakers, some who are with us in person and two who are online, from the World Bank, the World Health Organization, from FIND, from Unite Parliamentarian Network, and WHO. I'd like to, before I introduce them, like to give some context to this particular session. If we look at the funding gap for SDG 3, health, prior to COVID, OECD did an analysis that showed that the supply-demand mismatch, the gap for funding the SDGs annually is around 3.5 trillion. If you drill down and look at SDG 3 in particular, health, you're looking at a funding gap per annum of just under 400 million. So these are very large numbers. You drill down further and you look at hepatitis, viral hepatitis, hepatitis B and C in particular. Currently, they're receiving per annum about 500 million USD in funding. Now, that might sound like a large number, but the cost has been estimated that we need to eliminate viral hepatitis about 5 billion per annum. Now, for some comparison, it's nice to look at malaria, which is a little bit more well-known, more invested in. Currently, for malaria, we have an investment of 12 billion per annum, which isn't enough, but it's much better than hepatitis. Now, in terms of annual deaths, malaria, there's been some great success over the last couple of years. We're looking at, per annum, malaria kills roughly 400,000 individuals, so it's still a long way to go. Hepatitis, viral hepatitis, on the other hand, it's over 1 million deaths per year. So twice as many deaths, but only 5% of the annual funding that malaria gets. Both need to increase, but we need to see new investments for hepatitis. And that's why we're having this session. The key question for today's conversation is how can blended finance, that is private financing, philanthropic financing, blend with public financing, health systems financing, towards public health outcomes, in particular, the elimination of hepatitis C. And we'll look at some case studies, for example, from Egypt, as well as Georgia, where we've seen some great strides made towards financing the gap and actually eliminating hepatitis, which is, we'll learn about what are those models that we can replicate in other countries. So with that, I'd like to introduce the panelists. We have Mariam Yashi from Georgia. She was a former parliamentarian of Georgia, in fact, as well as the former president of the Innovative Financing Leading Group for the G20, and she's currently on the Unite Parliamentarian Union. She's chair of that. We have Thomas Palou from the World Bank. Thomas is a health advisor working in the Health and Nutrition Group, also based here in Geneva. We have Dr. Philippa Easterbrook, who is a senior scientist in the hepatitis and HIV team at the World Health Organization, also based here in Geneva. And online, who you'll see shortly when they give their presentations, we have Dr. Zhenya Dana, who's head of healthcare at the World Economic Forum. And we have Dr. Bill Rodriguez, who is the CEO of FIND, which is the Diagnostic Alliance. So we're going to be hearing from all of them, but I'd like to introduce Mariam, who will give our keynote presentation looking at innovative financing options for hepatitis and speaking from the perspective of somebody who has been in the government and actually seen real progress and been very instrumental in putting together financing models that work. So, Mariam. Yes.
Thank you, Greg. Greetings. It's a pleasure to join you in this very important event. Unfortunately, the pandemic has impacted the attention given to both other communicable and non-communicable diseases. So I believe that the theme of the session is rather overdue, and we have really missed the opportunity over the last 2 years to make a major change in towards elimination goals of hepatitis C. So, as Greg mentioned, I had the pleasure to work with the government as the Deputy Health Minister as well at the time when we designed the first hepatitis C elimination model program, and thanks to Gilead, Georgia is on track towards elimination goals. And also, I had the honor, together with Philippe Douste-Blazy, to be very actively engaged in innovative financing discussion as the president of the Innovative Financing Leading Group based in Paris. So let me share the perspective of the current situation as well as the various models of funding that might be mobilized for sustainability of hepatitis C resource allocations. Just to recap the global context, definitely, we all know that 58 million people are affected by chronic hepatitis C virus. Only in 2019, we lost over 900,000 lives, and annually hepatitis C is affecting nearly 1.5 million individuals. At the same time, 3/4 of people living with hepatitis C do not know their status, and that definitely aggravates the existing statistics. And based on the latest data, up to 16% of individuals who are diagnosed are following up with a diagnostic and treatment cascade that is extremely low if the adequate coverage and the quality of programs should be ensured. And finally, we have low coverage of HCV, hepatitis C prevention interventions as part of the needle and syringe or opioid substitution treatment for the high-risk individuals that are primarily affected by the infection. And if WHO 2030 targets could be met through the joint concerted efforts, we could be able to save 2.1 million lives by 2030, prevent 10 million new hepatitis C infections, and also bring an estimated economic benefit of $22.7 billion. As Greg noted, and those are the very well-known figures, we have 2.5 trillion USD gap per annum. That translates to over 22 trillion gap until 2030 for meeting the 17 SDG goals and 169 targets, related targets. We have 371 billion funding gap for health-related SDGs, and based on one of the latest calculations, 23.4 billion USD only for hepatitis C elimination efforts. And the reality is that we have limited, scarce resources of domestic revenues invested in hepatitis C, and the situation was negatively affected by the pandemic context. We still have official development assistance that is far lagging behind its 0.7 gross national income commitments, as in the OECD and other international agreements. And innovative financing is the single solution that can bridge the existing gap. We don't have any optimistic scenarios of major investments from domestic revenues or direct foreign investments or ODA expansion. So innovative financing might be the only solution for bridging the gap for not only for hepatitis C, but the health-related SDGs overall and broadly, ultimately, the 17 SDGs. And of course, we have the proven impact of innovative financing. I remember the time around 2010-11 when the skepticism towards innovative financing was rising. And even if we had UNITAID is an excellent example of innovative financing. Still, major international financing institutions were doubting whether innovative financing platforms could be sustainable. But fortunately, we see increasing both literature as well as documentation of practice and diversification of innovative financing platforms used by different development agencies or financial institutions. So that is very promising. And we have the proven record where innovative financing has actually worked. Significant progress made in health-related Millennium Development Goals before 2000, as well 2015, as well as current and future trends of sustainable development goals were made in 4 major areas: immunization, HIV, TB, malaria, very well known to the global public health community. And global public-private partnerships like the Gavi, the Global Fund, UNITAID have really played a critical role. And the global public-private partnerships were relying on a diversity of innovative financing approaches for reaching the results that Gavi, the Global Fund, and other partners have gained. And we're speaking about international financing facility for immunization, advanced market commitments for the new and underused vaccines that Gavi has supported through donor country funding assistance, pooled procurement of commodities for reducing the cost, debt to health by Global Fund and some of the OECD donor countries, tax levies and market-based solutions like Red Product. That is also one of the top innovative financing initiative launched together with UNITAID and Global Fund initiatives. So without innovative financing, the results that the major global foundations have really yield for the international community would never be achieved. So we have to learn from those experiences and try to build on and expand. So when speaking specifically for hepatitis C funding, how we can bridge the 23.4 billion USD gap? And we're talking about 4 interlinked factors that have to be equally targeted. Until a global solution for hepatitis C funding is established or found, we have to apply 2-pronged approach at national level and international global level. We definitely have to galvanize partnerships, because innovative financing is all about partnerships, both public, private, academia, civil society, and innovative industries. And finally, innovative financing is the way forward. So at the national level, the core foundation, the starting point, is definitely the national strategic planning process that will produce the costed, results-oriented hepatitis C elimination plans, and also identify both response programmatic and financial gaps. And international assistance or innovative financing or private investments have to be aligned around the national hepatitis C elimination goals as part of the universal health care. Alignment and governments should be requested to utilize existing services for reducing the cost of delivery of hepatitis C, like bundling, testing, or treatment of HIV, HCV, and TB that Georgia and some of the other countries have already implemented. Second, at the national level, is to explore local possibilities in innovative financing. And first of all, we are speaking about solidarity funds. And we have the example of France, India Corporate Social Responsibility Fund, and Czech Solidarity Tax that were implemented over the last 20-year period and were targeted for specific health gains. For example, Czech were redirecting solidarity tax revenues for disability programs. India has also introduced recently the threshold for the high income of corporations that are obliged to invest in corporate social responsibility initiatives. We also have a possibility of voluntary solidarity contributions and integrated platform of voluntary contributions like Tunisia, that over the 25 years is implementing the National Solidarity Day and has really made major progress in rural development and now supporting geriatric care facilities and disability programs. And Georgia has introduced, together with the Prime Minister, I had the honor to establish and to lead for 2 years the National Solidarity Fund that was mobilizing micro-donations, monthly basis, based from civil society and civil servants for supporting pediatric oncology high-cost treatment. And that was another national solidarity example. Pharma partnerships for cost reduction. The partnership with pharma industry can take bilateral agreements like Egypt and Georgia, where low-cost commodities were provided, or in the case of my country, free of charge DAAs were provided for the model HCV elimination program. Local manufacturer of generic direct-acting antivirals, similar to Malaysia or India, and joining other countries in voluntary pooled procurement. That is another innovative financing mechanism that countries can explore for reducing and lowering the cost of HCV programs. Finally, at the country-level partnerships, where we can explore results-based funding of corporate private service providers under the Universal Healthcare Package, or social contracting, results-based social contracting of civil society to reach the most at risk populations. In parallel, the global efforts have to be galvanized. And of course, we have to make the case of HCV investment and to consistently advocate at every high-level summit, including UNGAs or special sessions, EU, G20, B20, Davos economic forums. And we have to definitely strive for establishing a standalone financial platform facility for HCV, or merge with existing global fund or UNITAID. That would be very logical, since the communicable diseases are so interlinked, both in prevention as well as treatment and follow-up approaches. And one of the key opportunities for financing hepatitis C might be the blended financing. And blended financing takes different forms. Shortly, this is a strategic use of philanthropic or development and humanitarian philanthropic aid to facilitate better and stronger engagement of private sector, reducing the risks of private investments for better health gains. And we've seen the blended financing in the form of social impact investments like African Health Fund, where African Health Fund were supporting medium-sized enterprises for provision of primary health care services. Similar, we have seen the healthy nutrition initiatives in Africa, where small and medium-sized enterprises were supported for local production of healthy food. Results-based loans and credits, an excellent instrument for conditionality of credits and loan extension for countries, especially for middle-income countries that are withdrawing from support of global foundations, and the eligibility criteria is really narrowing the funding possibilities for middle-income countries while their economies are still fragile. So, for example, any health sector or budget support program, if linked with results of hepatitis C treatment and testing scale-up, that could really make a major impact at the national level. Volume guarantees and consolidated procurement, we've seen this with UNICEF for decades, procuring traditional vaccines, and later with Gates Foundation supporting cost reduction of contraceptives, for example, or through the Global Fund pooled procurement mechanisms. And again, advanced market commitments with an excellent example of Gavi pneumococcal initiative. And this is the last slide to summarize the other opportunities at the global level for mobilizing innovative financing. We can definitely continue discussions about global solidarity tax that could be applied for hepatitis C funding, similar to airline or financial transaction tax. But in reality, introduction of global solidarity taxes is extremely challenging, but this is definitely a theoretical option. It might be easier to experiment at the national level with different solidarity tax initiatives. Voluntary solidarity contribution from market products with transnational companies who have benefited from the globalized economies. There is a niche to really find industry, either sports or culture or IT industry that could be committed to specific cause of hepatitis C. And finally, the potential of blockchain and cryptocurrencies. Despite the discourse about transparency and the questions that still remain with the newly emerging financial space, there are excellent initiatives already implemented. For example, the World Food Programme is supporting Building Blocks initiative and using blockchains for financial aid transactions. And AidCoin and Innovation Norway is already using cryptocurrency for development aid. So those are the wide areas of innovative financing mechanisms. Some are very interlinked. Some might be perceived as parallel initiatives, but all of them have worked, both in health sector and most recently environmental health sector, the climate change initiatives. So we definitely have the experience to learn from, and definitely need a concerted action to lobby for more innovative financing for hepatitis C, because with the DAAs, with over 95% effectiveness of treatment, the possibility of real gain is very visible. Thank you.
Thank you very much, Miriam. Really appreciated how you looked at all the different options that are available, from what might be considered more traditional all the way through to, I mean, you included cryptocurrencies there, which I think is really taking us into a new area. And I think what I heard implied in that presentation is it's not a one-size-fits-all. Countries need to look at what's available in terms of current financing for hepatitis, and then see what would be the appropriate solution based on these different options, which have worked, as you've pointed out. So I think what I'd like to suggest is, in order to make it through all the different presentations, we just have one burning question, if there are any, now for Miriam. But then at the end, we'll try to save time for question and answers for everybody after all the panelists. So does anybody have any really targeted question? First come, first serve. If not, we will move. We can go to have those at the question and answer. Yes.
Thank you. I'm Michael Lepay from Médecins Sans Frontières. I have a question for you. I would like to know, in the case of Georgia in particular, in fact, if Gilead would have not come into play for this national program, how do you think, in fact, the government would have, in fact, engaged into this programming? Whether you had already considered other, in fact, these blended financing investment capacities, or any other, in fact, mobilization of resources. What was your sort of approach to that at the really initial stage of the elimination program? Thank you.
Thank you very much for the question, and thanks to MSF and MDM, the France-based civil society organization for active engagement in hepatitis C programs in Georgia. You're absolutely right. Without Gilead's support, the reality of starting national elimination program at the full scale would be impossible. Georgia was already implementing interferon-based treatment regimens for prisoners, 100% covered by the state programs, and through the public-private partnership negotiations, we managed to reduce by 60% price of interferon-based treatments, but definitely that was not effective, especially for all types of, all genotypes, and side effects that were, well known, that accompany the treatment course. In 2013, when we started the negotiations, we have to remember that the price of DAAs was around 80,000, and that was absolutely impossible for a middle-income country like Georgia, with up to 7% prevalence rate of hepatitis C, and around 200,000 estimated patients. So yes, back in 2013, Gilead's support was absolutely instrumental, though at the same time, Georgia's government invested in testing diagnostic capacity. So the government was paying for the diagnostics, and the treatment regimen was coming from Gilead support.
Great, thank you. And again, we can ask more questions at the very end. So Dr. Easterbrook from WHO, I'd like to turn to you. World Health Organization, you've been monitoring the burden of hepatitis. You've been looking at how are we doing to eliminate this disease, and also you're looking at financing. You've commissioned, for example, some global costing studies in the past. Could you give us a presentation which covers all of that, and what's missing? What do we need to do going forward? What's worked and what can we replicate? Thank you.
Thanks very much, Greg. Can you hear me okay? Yes. So it's nice to be standing up to give a talk. It's been a long time. I'm used to staring at a screen. And thank you for DNDi and partners for really galvanizing this conversation again. It's really long overdue for us to be now looking at opportunities for innovative finance. So in response to your question, I have some slides which will provide something of the WHO storyline on Hep C elimination. And so just to remind you where the story began, which was in 2016, with the launch at the time of the first ever global health sector strategy on viral hepatitis. And that was really a roadmap with targets, ambitious targets for elimination of viral hepatitis as a public health threat by 2030, so consistent with the Sustainable Development Goals. And elimination as a public health threat was defined as, and as shown on this graph, a 90% reduction in new infections and a 65% reduction in deaths compared to a 2015 baseline. And the schematic you see on the right is that, based on modeling, that these outcomes could be delivered by scale-up of 4 preventative interventions that's shown on the left part of the chart, reducing new infections, and then scale-up of testing and treatment to reduce mortality. So how are we doing moving towards elimination? Well, earlier this year, there was a launch of a WHO progress report, which provided new data from 2019 on burden, new infections, death rates, and the uptake of testing and treatment. And importantly, one of the additional values of this progress report, it was based on more than data from 100 countries, and all the previous data reports were on less than 40. So that was a real step up, but albeit very patchy. And the key messages were that great progress is being made, particularly led by certain countries. And compared to 2015, where only 1 million had been treated at that stage, there are now, more than 9.5 million who have been treated. So that represents a 9-fold increase since the 2015. But major gaps still remain. So we're still seeing, based on this 2019 data, 1.5 million annual infections, 290,000 annual deaths. The good news is that there's somewhat of a downward trend now in that new mortality estimate. And then, as shown here on the graph, which is very simply the proportion of those estimated who've been diagnosed, and then the proportion of those infected who've been treated. So that's the green bar and the yellow bar. So globally, as we heard earlier, it's less than a quarter who've been diagnosed, and overall 13% who've been treated. And you can see that there's a lot of variation across regions. The Eastern Mediterranean region does quite well, largely because of the impressive Egypt program, but you can see most of the other regions, there's particularly a shortfall in the treatment. So another development this year was the launch of new WHO guidance, well, the first WHO guidance for countries on how to go about validating that they've eliminated viral hepatitis. So an important step forward, a framework for what are the criteria and what should the process be, and really to motivate countries to accelerate action and to do this within a public health framework. And so these are just two tables that show you the options for countries. They can approach to start with validating B or C or both of them together. And then the other table is really the hardcore stuff. What are the actual measurements of new infection annually and death rates annually they need to reach, as well as program coverage? So what do countries need to do next? Well, I think the first thing is that we can learn so much from those trailblazers and so-called champion countries that have really led the way. Georgia is a prime example of that. You know, how through political commitment, through leadership, through progressively simplifying the care pathway, and of course, innovations in financing. And we have great examples from high-income countries and from low-income countries. Well, what will it take to achieve elimination? Well, a project that we initiated, WHO, with a number of other partners, pulled together and collated many of the experiences from these champion countries and identified 15 areas of good practice across the viral hepatitis response. So in governance, in strategic planning, drugs and diagnostics access, service delivery, and evaluating the response. And I'm just going to flag in a couple of slides two of these areas, so the service delivery and then the approaches to financing. So just as we learned from HIV that really simplifying service delivery is center stage in a global response, and moving treatment out of the specialty clinics into primary care, into harm reduction sites near where the patients are. And the opportunity is that hepatitis C treatment is so much simpler. In fact, super simple. I mean, as you've heard earlier, just for a 12-week course of low-cost treatment, which is well tolerated, to achieve a very high level of cure. In the recent history of science, there are few examples more exceptional than this, of where you have the opportunity for a cure. And this has now been reinforced by evidence based from a big global review showing that decentralization of care to primary care and other sites really does increase uptake of testing and treatment, and also being treated by non-specialists achieving similar results to specialists. So there are many examples now of this, of how adoption of this simplified approach really does result in a scale-up of testing and treatment. And so this is an example from Malaysia, through the progressive decentralization, how that really was the catalyst to scaling up. And we've seen similar graphs from Georgia and Rwanda and other countries. Doesn't seem to want to move on from this one. Right, now it does. And then on top of this simplification in the care pathway, the opportunity to nest in other innovations, be it hepatitis C self-testing, a point-of-care viral load, so that you can have testing and treatment on the same site, ideally on the same day, one-stop shop with test and treat. And that is really the future, a really simplified opportunity, and particularly appropriate for settings with marginalized populations and hard to reach. And then finally, on the financing options, as you will all be aware, unlike HIV, malaria, and TB, most of the global donors are not currently providing any support for hepatitis. And so the options are, and we've seen sort of different ways of stratifying this, domestic financing using the government budget allocations and with social health insurance, public-private partnerships, patients paying directly, and that may include private health insurance, and then the external financing sources, development banks, drug donations, payment by results. And inevitably, it often involves a combination, a blended approach, as has been outlined. And I think Egypt is a nice example. We'll hear that further, of building on the government investment, also being supplemented by the World Bank loan in 2017. And in India, where they have also, their domestic investment builds on the donor-funded investment in the infrastructure as well as human resource capacity from HIV and TB. So a very nice example. And just at the bottom there, I've given some other examples. I mean, it's not one of the core mandates of Global Fund to support hepatitis, but there are some examples of low and middle income countries listed here where they've been able to successfully get funding for testing and treatment for their HIV, hepatitis C co-infected. And then really, I think, very exciting is the expansion in the national health insurance schemes, which are constantly evolving and including some elements of treatment, testing and diagnosis. And then my last slide is really just on some of the messages and lessons learned from these experiences, and that really the importance of, MOHs need to make strategic decisions, which financing option for their country or which combination of financing options for different areas of their programs. And I think considering some of those 5 checks, the scalability, stability, what the size of the funding will be, does it create equity, is it feasible? And then I think, the other lesson is the need for the MOH, supported by civil society, to really be advocating both internally and externally, and the need to really have buy-in from key departments like the Ministry of Finance. And then I think very importantly, and this is from WHO, of really considering the financing for hepatitis within the overall context of universal health coverage and the package of care. And then just to touch on the drug donations, I think one of the reflections that emerged was that really the value in them being catalysts for, but not to sustain a national response, and that it's important that they're targeted and time limited. So thank you, and look forward to the discussion.
Great, thank you very much. Any questions from the audience? I may have one, if I may. Just on the financing options which you laid out, it appears that it can be quite fragmented, and what we've been hearing are different options. Is it a fair statement that in your experience in some of these countries, like for example, you mentioned Indonesia, DAAs are not covered by the health insurance currently? What in your view would be the role of either private investors or a donor to step in and, for a period of time, fund that in such a way that it catalyzes the insurance so that they can pick that up, over a 3 or 4 year period?
Yes, I mean, I think what we've seen as a consequence of there being no global funder is the need for governments to step up and to make that commitment and investment. But nevertheless, there being the opportunity for it to be kick-started, because often there is an inertia and diversion and distraction to other health priorities. And so I think starting with that commitment from the government, and I think perhaps breaking it down into more bite-sized chunks, and that's when other partnerships with a well-defined, circumscribed, be it in a province, be it in a district, can demonstrate success that can then galvanize the response. So I guess there's many paths to follow, but I think the idea that of that strategic catalytic funding at the right moment to get things to the next stage, and I think Indonesia would be a great example of where that would be an opportunity.
Thank you so much. With that, let's go online. I'm trusting that Bill Rodriguez from FIND is online, and he'll be providing an overview of the financing gap related to diagnostics. You know, one statistic that I've learned recently is 3 out of 4 people don't even know that they have hepatitis, so it's a real problem screening and testing. And yet, as you'll learn, the technology is largely there now. The price is not right, and the financing behind it is not necessarily forthcoming. So if we could go to, Bill, are you there?
I am here. Can you hear me?
Yes. I wonder, do we have a video feed as well?
Okay, great. I can see myself and I can see my screen, but I don't know if you can see me or my slides.
I think we
I'll wait a second and then I'll jump in.
One moment. We don't quite see you yet. We do hear you, though.
Okay. I'll just start by saying I wish I could join you there in person. Unfortunately, I'm in Botswana right now, and for obscure reasons that I don't fully understand, because we're good at surveillance and detecting COVID variants, we've become a pariah nation in the past week, and it's very difficult for me to travel, and I don't know when I'll get back to Geneva. So I apologize for not being there in person, but I hope to get back to Geneva soon. So hopefully we'll get the technical issues resolved and you can hear and see me.
In fact, so we can hear
okay,
you,
I think
we
I
see
see
your
my
presentation,
slides.
and I think they're going to work on trying to
Great.
have you visible as well, but you can get started if you'd like. Thank you.
Okay. My background and my appearance is not that interesting, so I'll just jump in here. Let me start by just crystallizing, I think. First off, let me just first say I really appreciate that we're having this meeting, and to thank you and DNDI and all the other sponsors and supporters. I think this is a really, really important meeting. Let me start by crystallizing something that each of the speakers has already touched on. And Greg, I think you mentioned it at the start, which was when you compared malaria to hepatitis C. You know, and I think in many ways, malaria was the paradigmatic disease of the 20th century. If you were a student of global health and you wanted to identify all of the challenges in global disease control, the approaches to integrated prevention, drug development, diagnostic test development, vaccine development, elimination strategies, program design, barriers to access, you know, integration with primary healthcare, the structure of the global health industrial complex, and especially financing mechanisms. You could pretty much just study malaria, and all of those issues came out. And then you look at where we are today, as you mentioned, Greg, and you know, there's plenty of challenges left in malaria control, but given the products we have available on treatment, on testing, on vaccination, the strategies we have, the financing mechanisms that are in place, if you look ahead to the goals and targets that we set every 15 years or so, we're on a path where you can see, you know, a path to malaria elimination and certainly control. And so I would say when you make that comparison, hepatitis C for me is the paradigmatic disease of the 21st century. And that's because of what's been said already today, which is we actually are developing rapidly. We're harnessing this innovation engine that HIV, TB, and malaria helped drive, and some of the structures in place to coordinate among partners. Some of the programs like Philippa mentioned that come out of WHO on policy and leadership. And we're moving rapidly, not just in hepatitis C, but in multiple diseases. And yet we haven't figured out the financing and the financing mechanisms. And so, and test and treat as a paradigm, if you look at all the diseases we're talking about globally as diseases of poverty, things like Chagas disease and leishmaniasis and schistosomiasis and hepatitis B and hepatitis C, and also cancer and diabetes, we're going to see rapid advances in the products we need to deliver high quality prevention services and care for those diseases, but we haven't figured out financing. And I think in that way, getting this right for hepatitis C is not just about hepatitis C and the tens of millions of patients and people living with hepatitis C. It's about all of the other diseases and the global health enterprise writ large, because we're at a point in hepatitis C elimination where everything else is really in place, except for how do we finance this. So with that in mind, let me talk a little bit about the challenges around testing and where we've come to. And so just by way of background, I'm the CEO at FIND. We're the Global Alliance of Diagnostics, and we've been really focused on equitable access to testing across multiple disease areas. And we've had a hepatitis C program since 2017. Let me see if I can share my screen. Okay, you can see that. Did that slide advance? Okay, there it is. So we've had a program since 2017, since we launched the Head Start project with significant, tremendous support from Unitaid. And the aim there was to fill the gaps in testing that still existed in hepatitis C, both on the innovation side, where we needed simpler, more affordable, more sensitive tests that could be used at more and more decentralized levels of the healthcare system. We also needed to figure out how to accelerate access to the existing tests, like viral load tests, in line with the WHO 2030 goals. So we were working across multiple countries on Head Start in Georgia, as you heard, in Malaysia, in Myanmar, and India. And we were intent on helping generate the evidence to show how new test technologies could lead to better health outcomes, be linked with care and treatment services, and lead to policy change. And really what Head Start showed, and this is really the critical slide for this, was just how much value for money a simplified program of testing and treatment linked together can deliver. So the impact of this whole Head Start project by 2030, with just a 3-year, $8 million investment across just 4 countries, is projected to be 20,000 cures, 1,600 deaths averted, and nearly $50 million in healthcare costs saved in those countries, which is a 6-fold return on investment. And that's the kind of economic argument that we're going to need to pull in financing mechanisms for hepatitis C elimination. And just to be specific with one example in Malaysia, and you heard a little bit of this from Philip a second ago. So we partnered to decentralize testing and treatment at the primary care level, including bringing new self-tests that were recently developed to market while WHO was coming out with a recommendation on their use. And this has enabled testing just recently now to reach new populations and increase uptake 70% higher than we'd seen with facility-based testing by using a community-based self-test strategy. Which brings us to the important point, which is the challenge really for hepatitis C elimination, and it'll extend to these other diseases like I mentioned, is that the cost, while the cost of an individual test and screening and technologies are there and are essential for elimination strategies, that cost will be the largest driver in many ways of those strategies, because you're testing so many people who don't have the disease just to find them. And so the important point is that there can't be a one-size-fits-all strategy for every setting, every health system, every country. And it's critical to make sure that each country can design a program based on available testing strategies, available clinical pathways that fits their environment. And that's one of the challenges. We don't have a one-size-fits-all strategy, and I think that was mentioned earlier. So we've worked with partners, many of you, to develop tools that can help you identify what is the cost effectiveness of different clinical pathways, different testing algorithms, different products linked to treatment. And that's now available as what we call the Hep C calculator, which was developed in partnership with groups in Georgia, in Malaysia, in India, and in Pakistan. And so that's another example of a tool that will help support arguments on how do we structure financing mechanisms in a way that makes sense. Next is just a comment on what we've learned from the pandemic and how we can harness that. And I would say, broadly, what we've all seen is an incredible acceleration of the opportunities in product development, program design, program rollout, and coordination across partners. And we need to capitalize on that energy, especially the emerging concept of test and treat for COVID, which we'll see roll out in the next several months with the new oral antivirals, and demonstrate how those programs can really work integrated in primary healthcare settings on the ground to drive control of a disease, and make that same case and that same argument for hepatitis C. Again, the cornerstone of what we believe to be a comprehensive program on COVID will be self-testing, which will roll out next year and linked closely to care through the oral antivirals. And that's obviously the same strategy that we have for hepatitis C. So we need to harness the energy, the support, the financing mechanisms, and the structures in place for COVID quickly and bluntly to say that this is a strategy that not only applies here in the pandemic, but can be used to deliver cost-saving results in other diseases like hepatitis C. And then I'll just end this relatively brief presentation by saying that in recognition of the ongoing equity issues and the disparities in access to testing and treatment for hepatitis C in LMICs, we've teamed up with DNDi, with MSF, I know you're there in the room, and with TAG to help launch Hepatitis C Pact, which will build on the track record of each of our organizations, working independently to now work in synergy and collectively across Latin America, across Asia, Africa, and Eastern Europe, and establishing some countries that can really take the next step from the pilot programs to comprehensive programs at a national level for hepatitis elimination and hepatitis care. And it'll address the four key areas responsible for low rates of access to testing and treatment, concentrating on increasing access to the PCR test in settings where that's appropriate, and the new generation DAAs, and cost-effective proven strategies for elimination based on test and treat. So I'll stop there. I think there's been a lot of great discussion already about what are the issues and what are the approaches to financing. I just wanted to make the point really that the tools are there, especially on the test and treatment side, and that what we need is a comprehensive approach to understand the drivers of costs of hepatitis C elimination, the strategies we have to reduce those costs, and how we can document and prove that the financing that needs to come and should come behind this is really money well spent, appropriately spent, not just for hepatitis C, but for all the other test and treat and disease paradigms we're going to see emerge in the next 20 to 30 years across multiple disease conditions, including non-communicable diseases. Thanks, I'll stop there.
Great, thank you so much, Bill. And by the way, the technology was working great, especially considering that you're calling in from Botswana. We could see you and also your presentation, hear you well. Just looking around to see if there's any questions from the audience for Bill. There was one thing I wanted to pick up on, and that is with diagnostics. Miriam and I think Philippa, you both mentioned the need to have more advanced market commitments, although you didn't use those words, but pooled procurement, these kind of mechanisms. Is FINE doing anything to try to drive forward those kind of arrangements so that you can, get the volume play in?
Yeah, the short answer is yes. The longer answer is it's proven very difficult. I think we spent a lot of last year trying to focus on that issue and trying to identify the right set of partners in order to develop a mechanism like you talk about with advanced commitments or procurement. And honestly, COVID disrupted a lot of that planning. The key person on our side, Sanyel Shilton, who's led our hepatitis C program and led a lot of the Head Start work that I just described, along with Elena Ivanova, who led the technical work on the test development with our industry partners. They were both co-opted for the same work in COVID. So they're leading our COVID self-test program right now. So a little bit of it was a bandwidth issue around COVID. And frankly, more of it was we just haven't found the right in and the right pathway to work together with the right partners. It's an ongoing discussion with Global Fund. I don't think we have yet clarity on how to move that forward, but that's one avenue. And then working with all the people who are in the room and interested in driving this agenda. We're eager to come at it again, as we get a little more control of COVID, hopefully, and free up some of our bandwidth.
Great, that's really helpful. I had my own bias in asking the question because it feels like it's really missing for both DAAs and diagnostics and any other commodities we need. So let's hope we can get something going for countries and maybe even at a regional level. So with that, then we'll move to Thomas from the World Bank, who is the advisor in health and nutrition. And I think you're going to give us an overview of the Egypt case study, among other things. So I won't tease too much. Yes, please come up. Thank you.
Well, good afternoon, and thank you for the opportunity to speak today. Just outset, I need to say that I'm not a Hep C or even infectious disease specialist. I'm more at home in health financing or health systems because that's what the World Bank does. So today I would like to give a little bit or discuss the issue a little bit from health systems perspective. Because, well, we will see why. And then, but referring back to the Egypt case, that is one case that we have where World Bank is actually supporting country government with the Hep C elimination agenda. Let me start with saying that how can we avoid the situation that we put hepatitis C in competition with all other priorities? That's what the ministries of finance don't like, that everybody comes to knock on their door and says, well, TB is the most important thing, or malaria, or HIV/AIDS, or NCDs in general, or maternal and child health. And that is only inside the health. Then the next day it will be education that says that education is the most important, that needs more resources. So what kind of toolkits countries can use to look at any health issue through a lens that makes sense and then make a case that needs to be financed? Now this is what we, in the World Bank we recommend is the health technology assessments. And I looked at the some synthesis studies that I could find online, about 40 or so in several countries, and they mostly turned out positive recommendations for the Hep C to be included for public financing and support, some unconditional, some conditional, and I guess it's depending on the prevalence in the country. And there are a couple of issues, of course, that we know that come to play in this kind of decision-making: the prevalence of the health condition, the effectiveness of the treatment, the cost, and also alternatives. And the cost already came up, and the cost is a very important variable because that may actually be the deciding factor. And I worked a lot on East Asia. I spent 12 years working with East Asian countries, and I know Thailand very well, who debated, and they are strong in health technology assessment. They were debating whether and how to introduce HPV vaccine. And they ran the health technology assessment that it came out negative. And the cost was the deciding factor. 3 years later, when the costs had come down, it was included in the essential services package for the government financing. But leaving this financing aside, I just really think that advocacy, awareness building, the bringing attention to the issue is very much needed, and is something that really the Hepatitis C Pact or coalition can do. I'm giving this heads up because hepatitis C has really a strong case if you apply this instrument. I'm not trying to discourage, But actually, I would say that hepatitis C will do well if you apply these instruments. Take the Egypt example. And of course, well, it's been referred a lot, and Egypt is a country that had a very strong political and high-level leadership to push the issue. To my knowledge, there was no HTA analysis applied in Egypt, but Ministry of Finance kept asking these questions. What is the economic case? And actually taking this up. And of course, in Egypt case, the numbers are up there in the screen. On the screen, the case was very strong. It had, we can calculate the economic cost on the society, what happens, what is the impact on the households, what is really important, that really is even no-brainer for anybody who will consider surge financing needed to eliminate Hep C, is the very direct and fast financial return. You go and search, and then you will reap in the benefits very soon. In Egypt's case, in 6 years, the investment will pay off. This is superb return for anything, I think, with Ministry of Finance to say to invest in. So, and of course, this is even net of health impact, a healthy life years gained, or the boost of the life expectancy. We usually use the term of disability-adjusted life year averted for the cost-benefit analysis, and WHO says anything that is in between 1 to 3 times GDP is cost-effective. Well, in Egypt case, they calculate a little bit different. They said what is the cost of actually life years saved, and it came down out just 10% of GDP per capita. So very cost-effective. So hepatitis C would really make a good case. And then topic of today's discussion, so how to mobilize funding. And already some points have been made. And the funding initially is needed for surge. And look at the graph here. There is initially more resources needed. Countries can do different things. They can try to mobilize it domestically, prioritize, or even do some sort of short-time levy. In the COVID case, we know that India introduced a short-term alcohol levy to fund short-term acute COVID response there. So external financing, development banks, and I'll say a little bit more on that, and this already was mentioned earlier, or social impact financing would be great case for the private sector, especially socially minded private sector to invest in, because you can see the returns impact very quickly. And there are, from a development bank perspective, in Egypt, the bank is supporting the agenda with the $350 million. It happens to be almost exactly as the cost, the more additional cost that the country needed to implement the elimination program or the surge needed. But this was a classic project, investment project. We now have this new results-based instrument. We can actually disperse and help countries, what we call based on disbursement-linked indicators. So that especially if you make progress against certain benchmarks, you get resources. We've seen that it's a great incentive for countries to actually implement the agenda they say they would. We have also historically done buy-downs, especially on polio eradication. With Rotary International, with Gates Foundation, they put up resources that would buy down the loan that the country takes from the World Bank against certain criteria on that is benchmarks on the polio elimination program. And it worked effectively. I think it was applied in Pakistan and Nigeria. So at the time, it was since almost 20 years ago. And mentioned already cost argument, that I think Egypt is again case to see how quickly and how importantly the cost came down, that actually made the campaign or the elimination program more cost effective and affordable for a country. Just a little bit on the Egypt case. I mentioned already the high-level political commitment that was behind this very successful 9-month mass screening campaign that reached 79% of adults. But I would really like to see is what is happening to this cascade, what we can almost apply to any health conditions, and we do it now increasingly with NCDs on what's the prevalence of the problem or a condition in the population, how to find out actually the people who actually have it through the screening program, a test program, and then be effectively finding them, diagnosing them, putting them under treatment, and actually then achieving cure. And Egypt has been magnificently successful with that. And that all came out of this surge that I mentioned earlier. Also looking at some of the design issues that are important, if you look at a little bit more the health system's perspective, is that there was bundling with NCD screening. Overall, it was not fully vertical single issue intervention, and there are some mighty solutions as well that have a wider use that I'm getting right into. And how would one integrate into the universal health coverage agenda or health systems agenda the elimination? So in Egypt case, initial campaign was very vertical. The Ministry of Finance directly financed the key inputs, the antivirals and tests. Staff was mobilized from the general health system, but put specifically to work on elimination program for 3 months. So you can ask a question, so what happened to the other services at the time, but we saw on the previous slide that they did some task shifting and other ways to keep, I think, the rest of the health system or health services going as well. But it was also helpful for some general health system strengthening areas, the creation of the national NCD program, and also some electronic health or digital health solutions. Where they are right now they have done the acute phase, the surge phase, and now the question is how to integrate it back to the health system so that you have continued screening, and Egypt is doing it. They have everybody who shows up in the hospital gets an assay of tests. That includes also screening for hepatitis. And then it's also integrated into the pre-employment medical checkups. They also established a number of freestanding liver facilities that are now, I understand, mostly empty. So they need to be also integrated back to the health system somehow. But I think Egypt overall provides a really good example how they have, well, it was the highest prevalence country in the world as well, at least according to the information I got at the time, that how they made a decision, how they provided leadership, how they managed the campaign, and how they are now also integrating the issue back to the health system and universal health coverage system, because they still cases are likely to show up. They still need treatment, and it's still much more cost-effective than letting over time complications develop. So thank you very much.
Thank you, Thomas. Just in the interest of time, if you do have any questions, we'll hold them to the very end. We have one more presenter, Dr. Zhenya Dana. She should be on the line from the World Economic Forum. Yep, we see you. Can we hear you? Yeah.
Hello, everyone.
Hi. So over to you. I don't think you have any slides, so we're all ears. And if I may, we're, I think, very keen to learn more about also public-private partnerships, and I think you would be in the right position to talk about that and the initiative that you're looking at with hepatitis, and also could it even be on the agenda in Davos? So thank you.
Thanks, everyone. And it's a pleasure to be able to share a little bit about the World Economic Forum's thinking and supportive role that we're playing in the fight to eliminate hepatitis. So my name is Zhenya Dana. I'm head of health and healthcare for the forum. What we really excel at doing is being able to set the table and bring together stakeholders at the highest levels of government, of industry, civil society, academia, international organizations. So we are in the healthcare space tackling a number of issues right now, and the hepatitis challenge makes total sense to us. We've seen the numbers already today during the presentations. The ROI is definitely there in terms of being able, and demonstrated, being able to eliminate hepatitis according to the WHO guidelines. So the question really is why isn't it happening? Why aren't more countries just jumping onto this this case the way that, say, for example, Egypt is at the very highest levels? So that's the kind of the nut that the forum wanted to help crack using our platforms and our convening ability is how do we bring together and raise awareness at the highest political levels around the opportunities and the ROI from eliminating hepatitis, and be able to share those stories that it is possible. There are many countries that are making exceptionally good progress toward these goals. So that is one key area in which we would like to use our platform. Our platform does include, of course, our annual meeting at Davos and other meetings and convenings that we do throughout the year. And then also taking advantage of our partners. And our partners do include a lot of public figures and governments. So how do we bring the issue and the success stories and the needs around financing models, and the capacity building needs to those levels of political leadership where it really makes a difference. I was really interested to see the presentation from World Bank on the development bank side of the financing equation, and we have taken a really deep dive in the forum, looking at the sort of spectrum in which financing requests get put together by countries and how they make their way up to financing institutions. And we have found possibly some room to maneuver there, in that we are understanding that health ministries are only one ministry of many that come together or come forward with their priorities to finance ministries, who then take that package of requests or make those decisions really about what makes its way then up the chain, really, so to speak, to places like development banks. So we want to be able to use the World Economic Forum's platform to be able to highlight again and kind of unlock the critical understanding and connections, and show additional collaborative potential to by convening and bringing in particular finance ministers for alongside development banks and additional funders that may be out there and are very interested in thinking about how to incorporate hepatitis in some of their broader health system strengthening or universal health coverage plans. So this is a work in progress for us in terms of wanting to figure out where do we play the best supportive role for the work that is happening out there. I mean, I'm just struck by these presentations about how competent and how sophisticated and how dedicated the community is to already unlocking the opportunities and providing the evidence. And so what is it that the World Economic Forum can do to accelerate and to elevate the good data that's already out there, the stories that are already out there? We also want to be able to bring our industry partners to the conversation. I was listening to the presentation from the situation in Georgia and recognizing the role that pharma played in the treatment program, but also our diagnostics partners as well. So we want to be able to include and have at the table and these convenings at the political level, our private sector partners, and be able to set the table so that they can help contribute and map out appropriate cost estimates and pricing in partnership with a multi-stakeholder group, so that we really bring the industry voice to these collaborations. So I think in summary for us, the forum is new really to thinking about hepatitis, and has been, thank you for the warm welcome into the community, and wants to really use our platform to be able to raise that political awareness, find the avenues where the good information is not yet getting to the right places, and to be able to use our platform to show that it is eminently doable, that elimination is possible, and how it has taken shape in multiple ways in other countries around the world, and to play a little bit more of that matchmaker role, where we can partner up countries and other institutions who have made that successful, have made successful campaigns happen, partner them up with others who are interested and learning about the benefits and the ROI really of eliminating hepatitis. So we want to continue to play that convening role, that awareness raising role, and the ability to get this on political agendas. Thank you very much.
Thank you, Zhenya. So in our last 5 or 6 minutes, I mean, we have to land this very deep conversation, covered a lot of ground. But before we move to close, are there any comments or questions to any of the panelists? Yes.
Yeah, hi, my name is Craig Courtney from ISF Advisors. We're a boutique advisory firm that focuses on how do we bring together access to finance to private sector players, but also on the public side. So how do we make sure that all the players in the ecosystem have their access to finance? I have a question for Thomas from the World Bank. You mentioned, the Minister of Finance gets requests from various ministries. And yeah, I mean, I worked on privatizations for a number of years and understand those dynamics. And we've seen a certain trend, and you have hepatitis C, you have NCDs, you have all these different, these kind of asks that are coming in, and certain ministers of finance don't want to have earmarks, and there's all those kind of dynamics that can get into public finance. But at the end of the day, we have seen an increase in thematic public bonds. Obviously, everybody's coffers are going to be very tight these days. But we have seen them done in Asia with Asian Development Bank in health. We've seen them at the Inter-American Development Bank done in education, where it's really, targeted for either a single government or a series of governments to fund certain line items with outcomes. Now, I just want to ask if you've seen more of that, and is there a broader appetite for a health financing type structures? Because as COVID, if you look at the institutional investment market, there's a huge appetite there, and the most liquid and easiest bonds are government bonds to buy, particularly if they're backed by, if you have sweeteners like from Gates or FCDO or whatever else to come in on the pricing and this type of thing. There's a huge amount of institutional money that is already being drawn upon to fund for what's going on, in the government coffers around the world. But couldn't we move towards, if we want to address the top priorities like Hep C and some of the other wins, shouldn't we be giving those ministers of finance is what I want to say, shouldn't we be giving them solutions to how to finance, in terms of, you mentioned a tax, domestic resource mobilization, but financial market solutions that are thematic towards it'd be hard towards a single issue, but towards a broad health agenda. Is that something that you've seen more at the World Bank? I mean, in opportunities, is that something you're working towards, or it's a broad? I'm sorry I set the seat a bit, but to to me, it's super important that the ecosystem on the public side gets financed properly. And, we obviously want ODA and to be replaced in the long term, right? And so how do we get that replaced on line items within governments at the national level, and giving them opportunities to have public financing mechanisms, bond offerings, this type of thing, to a hugely demanding institutional market? It certainly has to be a path, but I don't know how the World Bank is looking at that.
Well, I'm not perhaps the best person to discuss the technicalities of this, but again, I can say this, that in our engagements with the ministries of finance over the last few years, we've been really making a case that spending on health is actually investment. We use the human capital argument, and what we are hearing back from ministries of finance is yes, that they are getting the idea that they need to spend more, and now there is, of course, the additional more is for the preparedness they need to do. But the next question for them is how to make sure that additional resources are spent well. This is something we engage a lot, and I think the returns that hepatitis C provides, if you actually implement the program well, and if you do with some conditionalities, this can happen. Now, on fiscal space and how to raise the more, I think that is the question. And I think our macro people are working with, in each country, they are looking at options. It could be domestic revenue mobilization options, could be external financing. So all options are on the table. If there is a convinced that they need more money for this particular purpose, and this money will be well spent. So, and we do engage, but also in the World Bank side, of course, we are the banker for the Global Fund, and also CEPI and all various. We had pandemic emergency financing facility that was a market-based insurance operation. That was, perhaps some people thought that it would not work out very well because it took time to mobilize in the case of COVID, but it eventually did and paid out more than actually it cost for the bank to do the scheme. So we are engaged in this market-based instruments as well, but this is not a little bit out of my expertise, given that it's our different people in the bank who work on this in this space. But thanks for the question.
Yeah, thank you, Craig. See one more question, and by the way, the Hep C Pact, which some of us are part of, this new movement, a development impact bond at the country level is in fact on the table. So we have 2 countries lined up where we want to have that discussion. So, yeah. I think it was yes.
Oh, yeah. Really, thank you very much, because it was really enlightening. I don't know whether I've got a question, but just listening to what you said about hepatitis C just remind me about TB, what I've been working on in the last 8 years. And it just sometimes made me mad to think that what has achieved with COVID in such a short time in terms of diagnostic, treatment, and vaccine, and what close to nothing has been done for TB and then also for hepatitis in such a short term. So while I was looking, for example, even for TB financing, was always this problem of like private capital really wanting to invest, and the only probably solution is always private partnerships. But ultimately, I don't know what you think, but I think for hepatitis, as for TB, it's a lack of political will, and then it's a lack of visibility. I don't know whether the World Economic Forum or what will be what can be done to raise awareness of that, and maybe for sometimes it would be good to combine synergies, like, for example, for the testing, I think I understood correctly, combine the test with the COVID with the hepatitis, and for the same of TB, so that you maximize, because the problem is that a lot of people don't know to have hepatitis, and if they don't know, I mean, they can even transmit. So it's really a challenge. But yeah, I guess it goes more than financing. It's really probably at a political level before going to the financial level. Thank you.
Thank you for the contribution. Would any of the panelists like to respond? Philippa?
Well, I was going to ask a question, so
okay.
maybe I'll have the others respond to that point. Yeah.
Thank you for your question, and I would also like to reflect on the previous question. You're absolutely right. I think what the global health community is missing is the integrated, truly holistic approach to universal health care. This might seem like a buzzy words and terminology in terms of the global movements, but with all the successes of HIV/AIDS, with all the successes of COVID, unfortunately, we are still moving with silo approaches and not utilizing fully the shared opportunities of health systems and their service deliveries. The World Bank, couple of, maybe 2 decades ago, started the marginalized budgeting for bottleneck tool. That was the attempt to integrate the possibility of funding health systems. It didn't work. One health tool was another promise of international health community, and with some major investments, unfortunately, not many countries have been using fully the tool, and maybe it's not very user-friendly. That might be an issue. But definitely, on one hand, we have not to forget the individual disease components, but we should not also lose the sight that any of the disease specific programs should be part of the holistic approach, and the overall health advocacy should be on the highest political agenda. Because next day might be the cancer issue, cardiovascular diseases, rare diseases that are actually lost out of the financial affordability spectrum. So if, of course, the World Bank, World Economic Forum, and the really change maker platforms and partners can really back up the health advocacy, and pandemic actually helps the context that health has a multi-sectoral effect, then we might also progress in terms of integrated approach. Thank you.
Thanks. I would just like to take the opportunity to ask a question to my sort of 2 panelists here in person. Given that I think we're all agreed that the advocacy for financing opportunities is absolutely center stage, and given that will often come first from the Ministry of Health as they're putting together the National Strategic Plan, financing proposals, doing the sort of the budget, and hopefully supported by civil society, what tools are out there, simple tools, which may be well known to ministries of finance, to help come up with a kind of portfolio of options? Because it's the Ministry of Health, it's the ones that are going to be the primary advocates, and being as well informed about scenarios and options would help make the case and advance things. And I just wondered what is out there that would help them at least get through the next stage and exclude ones that are using a simple checklist. It probably is a great one for AI at some point, so that they can start to build that case.
I don't want to seem very pessimistic, but frankly, today, if all the ministers would be the health ministers, as we used to say, and if you would be given the carte blanche of prioritizing within the health sector, there is no single tool that can actually hierarchically prioritize the investments in the health sector. Yes, we have the One Health tool. Thomas mentioned the technology assessment approaches that is very useful for specific health component intervention, but not comparative analysis of the investments in terms of more advantageous or disadvantageous kind of financial allocation area. So this, I'm really happy that the issue came up, because for years, even with our dear late Hans Rosling, we have been discussing this. The world community, the global health community, needs new integrated health system assessment and prioritization tools that can really help the governments to prioritize more wisely and to make a stronger case with the Ministry of Finance and the international financial institutions for alignment. As of today, the options are very limited, but definitely it would be very beneficial to invest in development of new tools.
And it was more financing options rather than just making the case. So of all the different array of options, what might be the path they would pursue?
Well, I wish I had the answer to that, but in real life, of course, the countries operate that they want to make incremental changes because they rarely have an opportunity that we start like on a clean sheet and say, well, what would be our first priority? Then, as I mentioned earlier, ministries of finance are getting warmer, that they need more, put more into health. The next one is, what is the incremental return? And I think what I mentioned earlier, in Egypt case, there are arguments that you can make for the ministries of finance that they listen to in terms of what is the economic impact and what is the impact on households on this particular problem. And if there is an effective new technology with costs coming down, I think that even makes the case stronger. And that is the first step. And then, of course, if you are on the Ministry of Finance side, they need to figure out how they will finance their whole expenditure package that they have across sectors that may be more than they have revenues for. So, and then they look at the what we had the discussion before. So, what kind of options they have to mobilize resources. I want to also say that there are similarities. Also, we should look at TB was mentioned, and I think you look at TB and hepatitis C, you can look at in very similar way. Actually, we currently have a $400 million operation in India that is for TB, that is brought down by global fund financing to make it more attractive for the government to take the resources. And that is also sometimes important. If they can get concessional financing, even to make more concessional by blend, they are more willing to take this financing. And we are in discussions with some other countries doing very similar. Diabetes and hypertension, they have very similar cascade issues. They have prevalence out there in the society. People don't know. We know the consequences are that significant and costly to the societies. You can apply the similar thinking, but I want to make again that the hepatitis C will stand out because they have such a clear path for economic and health return, given the technologies that are available now for the countries.
Great, thank you. I don't want to interrupt this really robust discussion, but I think we're cognizant of the fact that some of you might have obligations to get to. We are past time. So I think in the interest of time, if it's okay with my panelists, I'll just say a few words, not to try to summarize because there was just far too much, but maybe a thought for all of us to take away. It's been mentioned that the investment gap for viral hepatitis, so talking not only about hepatitis C, but also hepatitis B, could be around 4.5 billion per annum, because right now we're looking at about 500 million, which is spent, but we need to get to roughly 5 billion. Malaria already has double that in terms of spend. So someone mentioned political will is missing. Another, all these tools and approaches we've been speaking about, they're useful for, I think, advocating to the donors, to the investors. We need private investors. We need real investors in this. And to the governments to increase domestic resource mobilization, to increase donor grant giving, and also concessional lending from some of these investors and development banks. And to put a plug in, we have started a financing coalition for hepatitis, which is really a community of practice where we're inviting those from development banks, from donors, investment companies, impact investment, advisory firms, to join us as we think about how do we, tackle this together, because clearly we have to do it together. And we're doing it at the national level. It's not just global. It's really going down at the national level. Do I see a hand? Craig, you wanted to, yes?
The question around what are the mechanisms and what are out there.
Yes.
I did a piece of work with Rachel Mitchell from University of Washington, another lady from the University of Cape Town for the NCD, Global Coordinating Mechanism for NCDs at WHO, around various financing. So SCI has domestic normalization, it has ODA, and then it covers financial mechanisms. And it's written for, and it's public. It's on their website. You look up Global Coordinating Mechanism, NCDs. They had one for the private sector and one for financing. But in there, the document really sets out, it's written for member states. It sets out some of the modalities I think would be applicable to across obviously, various issues. And so just to point people in that direction, because you asked that question.
No, thank you.
Sorry.
No, that's perfect. And that's the kind of insight. So with this coalition, please do talk to one of us from FIND, MSF, TAG, DNDI, so that we can get these kind of ideas and build solutions for financing. So I think with that, unless there's any burning comments from our wonderful panelists, please give a final round of applause to them, and thank you.